and more people are getting detected with lung cancer who actually are non-smokers.
Patients don't have symptoms till the mass in the lung is pretty large. It's typically stage 3, stage 4 by the time they get detected. Stage 3, stage 4 survival rates are less than 5%.
How does AI work? Like, how does it detect something that maybe even the human radiologist cannot detect?
Humans, when they look at a scan, they're looking for something specific. I'm looking for TB, I'm looking for pneumonia. I'm not looking for that patient potentially having a nodule which could be lung cancer. AI is very comprehensive there, right? It's just looking for everything that is on that scan, and it is able to point out, especially lung nodules, and some of them could be lung cancers.
For you as a company, are you liable if you make a mistake, or is a doctor liable? Prashant, welcome to AI Across Borders. It's such a pleasure to have you here today.
Thanks, Aisha. Great to be here. Thanks for inviting me.
Prashant, there's so much news these days specifically about lung cancer. And I kind of want to start over there because my friend's mom was diagnosed and she had never smoked a cigarette in her life. And in fact, more and more people are getting detected with lung cancer who actually are non-smokers. So for people like those, how could Qure.ai have helped?
There are basically multiple challenges to lung cancer diagnosis. See, symptomatic patients don't have symptoms till the nodule or the mass in the lung is pretty large, right? So it's typically stage 3, stage 4 by the time they get detected. And so you don't detect early for those patients, right? So there is no symptoms when the cancer is still small or early. So you cannot detect symptomatically. Now, the second point is a lot of countries do CT-based screening, right? So you can go and get a CT done, a low-dose CT scan in which you can see a nodule, which could be a sign of lung cancer. But the problem with that is two things, right? One is that there is a very small set of people who are eligible for that. And it's typically smokers who have had 25, 30 pack years, typically people who are 50, 55 and above. And the guidelines are different for different geographies. So basically, it's older people who have smoked for a long time, right? And that basically misses a large set of people who are, like you said, non-smokers. About 20-25% of lung cancer is diagnosed in non-smokers. There are people who are under 50 who get diagnosed with lung cancer. Again, those people are missed in that kind of screening program. So that's why we said that why can't we look at routine X-rays, right? All of us take X-rays for routine reasons. We do medical checkups where we do chest X-rays. Can we look at routine chest X-rays? And on those routine chest X-rays, can we detect a nodule and potentially identify the riskiness of that nodule to be lung cancer? And then if the nodule seems risky or a high-risk nodule, then you basically send that patient for a follow-up CT scan. And from then onwards, you can basically do multiple follow-ups or a biopsy and confirm lung cancer. But that's sort of what we started with, the idea that there are 1.3 billion chest X-rays around the world taken routinely. And on these routine chest X-rays, you could find signs of lung cancer, which can then be used to diagnose early stage lung cancer.
And early stage is much more treatable.
Stage 3, stage 4 survival rates are, 5-year survival is less than 5%, right? If you look at stage 1, stage 2, 5-year survival is upwards of 85%, 90%. And again, depending on therapy, geographies, there is a lot of differences there, but survival is very high if you diagnose early. And idea is that how do you figure that out? How do you figure out if somebody has early lung cancer?
And Prashant, is there an example you can give of somebody who detected it earlier with Qure.ai? A real patient example?
We have multiple examples. There is a patient in Scotland. She was supposed to have surgery for something else. And she went in to get a chest X-ray. On that X-ray, we identified a nodule and said that this could be a potentially risky nodule. And that patient went on to do a CT and, of course, got diagnosed early with lung cancer. There was a patient, and these are all patient stories that are available on YouTube. There is a patient in Chennai that I interviewed about 6 months back. He, again, similar thing. He went in for a routine chest X-ray and Qure flagged a nodule, which led to the radiologist evaluating that patient for a potential lung cancer diagnosis. Did a follow-up CT, got diagnosed, got surgery, and got cured. So many cases coming through, across the world, India, UK, Thailand, Vietnam, Turkey, many places where we have seen patients diagnosed early because of Qure. See, we are just an ambient AI looking at every scan that is taken for a routine reason, right? So if we find a risk, I mean, let's say there are 100 scans taken in a hospital on a day, we might find one that is potentially at risk for lung cancer, and that patient then needs to sort of get followed up with a CT. So we enable that to happen across these hospital systems.
And Qure actually does not only lung nodules, right? There are like 2-3 other diseases that you check for also. What are those, Prashant?
So we started our sort of biggest product to begin with was TB screening. And this is one of those areas where sort of we bumped into it. I mean, we didn't realize that there was such a huge gap in TB screening. But when we started building out our chest X-ray AI, we said we could detect 30, 40 different findings on a chest X-ray using AI. And that could be an assist to a radiologist, could be potentially augmenting radiologists in certain geographies. And one of those findings was TB, tuberculosis. And what we realized is that TB screening, the primary investigation that you do for TB screening is a chest X-ray. And the challenge there is that if you're looking at countries in Africa, for example, Malawi has got 2 radiologists, Kenya has got same number of radiologists as just Mass General Hospital. We're talking about Liberia, which has 0 radiologists. So you have all these countries where radiology is not available. Chest X-ray interpretation takes weeks or months, right? One of our first customers in Philippines, it used to take them 2 to 3 weeks to get an X-ray read. And that is where we came in and said that we can actually interpret that X-ray within 20, 30 seconds. And the TB screening protocol, which is take an X-ray, the X-ray is positive, you do a sputum test, which used to be multiple weeks long, now can be done in a single day, in a single hour. And that was the change that we brought in. And WHO in 2021 said that Qure solutions can be used autonomously in the absence of a human reader.
Wow.
And you have absence of human readers across all of these geographies, including rural parts of India. AI is typically faster. I mean, like I said, it's weeks versus seconds. AI is more accurate. Multiple studies now which show that AI, as compared to human readers for detecting tuberculosis, is more accurate. And AI actually is cheaper also, because getting a radiology read in certain parts of Africa, certain parts of the world it's quite expensive to do that, and AI can be substantially cheaper than that. So we enable a lot of these TB screening customers to manage their programs, and we probably have screened upwards of 25 million patients for TB in the last 5 years.
That's an incredible metric, Prashant, by the way. And now you're also looking at heart scans also? What is next?
On chest X-rays, chest CTs, we do a lot of different things. I mean, the idea is that how can you use AI to find things which might have been missed, right? So TB is one of them. Lung cancer, we have a lung cancer risk score. Like I said, we have a COPD risk score. So we can detect risk of COPD on a routine chest X-ray. We can detect risk of COPD on a chest CT. We detect risk of heart failure on X-rays and CTs as well. So multiple disease areas that we are getting into from a chest X-ray and chest CT perspective. And all of this is powered by a follow-up management program, so something called Qure.ai, right? The reality is that you tell a patient that there is a potentially malignant nodule in their X-ray, they should do a CT. They still may not come back, right? And the doctor may not, so you have to also remind the doctor to call up the patient and tell them that they have this nodule and they have to come back for a CT. So managing that follow-up, making sure that patients come back for the follow-up is also a challenge that we solve through agentic AI and a tool called Qure.ai. So we basically take it on from the time that a nodule is detected on a chest X-ray all the way to potentially a biopsy being done and a patient being confirmed with lung cancer, or in the case of TB, being confirmed with TB. So a lot of end-to-end diagnostics we support through our portfolio of products.
How exactly, for our non-technical audience, how does AI work? Like, how does it detect something that maybe even the human radiologist, as you said, cannot detect? And how can it do it so fast?
So that speed is function of the kind of compute you have, right? And how does AI do it? I mean, it is basically learning from a lot of data. How we train these algorithms is we have about 1.5 billion images in a database, and we have corresponding annotations for a large number of them, where we have gone out and marked where potentially a nodule is, or where a TB, let's say for TB, there is cavity and consolidation, certain things that you're looking for, where those findings are. And we have millions of those X-rays and CT scans with those regions of interest marked out. And through these deep artificial neural networks, we sort of pass on this data, and these networks figure out how to identify those abnormalities based on the data that you presented to it. And we use multiple kinds of annotations. We also use data from reports. On a report, you can figure out where the abnormality is. So we can say, okay, there is a nodule on the left lower lung. So we can actually use the report also to figure out where that abnormality is, use that to annotate scans. And all of this sort of goes into a large neural network, which then figures out on its own what the abnormality is, where it is. Humans, when they look at a scan, they're looking for something specific, right? If I'm a radiologist and somebody comes in with a cough and fever, I'm looking for TB maybe, right? I'm looking for pneumonia. I'm looking for certain things. I'm not looking for that patient potentially having a nodule, which could be lung cancer. AI is very comprehensive there, right? It's just looking for everything that is on that scan. And it is able to point out, especially with lung nodules, there are like really, really small nodules which get missed very often. And some of them could be lung cancer. So we are able to find those because the AI is comprehensive in its search. And that's how it can outperform humans. I mean, otherwise I would say, the AI is trained on human data, so it is performing at the level of humans. It's not superhuman, but it is comprehensive, so it becomes more accurate at many tasks.
Where do you get this data from? Do you have partnerships with universities or customers or academic institutions, or this is open source data?
We partner with a lot of research institutions. We partner with hospital systems to get anonymized data that goes into training our models. And this is across the world. I mean, we procure data from the US, we procure data from India. There are certain data partners who do this. I mean, there are companies that just do this. They work with hospitals to create data pools that can be provided to companies like ours for training our models.
Are there differences in between people of different countries, or does it present itself the same way, the risk or the identification? Can it even go down to whether I'm like South Asian, so there's something different about my nodule being risky versus somebody who is French, for example? Or that is not the level we've done yet?
I mean, the anatomy remains the same. So again, I'm not a physician myself, but from whatever I have read and studied, anatomy remains the same. So from a radiology perspective, the way a disease presents itself remains the same. We don't see a difference there. But the prevalence of disease might be different across geographies. For example, what happens a lot in India is that people confuse lung cancer for tuberculosis. Nodules in the lung also could be a sign of tuberculosis, and tuberculosis is way more common. I mean, we have 2.5 million people with TB in the country, in India. And so doctors see that more often. So when they see that nodule, they feel like, yeah, this could be a TB case. The patient starts on TB treatment. And only after several months, they realize that maybe that was not a TB nodule, or it was not a case of tuberculosis. So that happens. And the prevalence of TB, for example, in Europe or US is going to be very low. So there, a presence of a nodule might actually be more likely to be cancer. So I think those prevalence differences are there, which sort of change the way patients get treated and get diagnosed. But the way a disease presents itself on a scan does not typically change with ethnicity.
Prashant, this seems like something great to have, but it also seems very expensive, even though you said can be done at a laptop. Is this a rich man's or rich woman's access to have AI look at these kinds of scans, or do you see that Qure can be used by everyone?
Honestly, it's a very limited additional cost on top of what you're already doing, right? I mean, if you are doing a chest X-ray, this AI is sitting on top of that, just processing that as you take that X-ray, and if there is a risk that comes up, it flags that risk, right? And the cost of that is very less, I mean, cents or max couple of dollars, right? Across X-rays and CTs, across geographies, the price varies, but it's very cheap. I mean, typically the cost of doing a chest X-ray in a country like India might be $10 to $15. Outside, in Europe and US might be hundreds of dollars, right? So, and the best part is that we don't require a new investigation to happen. We don't require patients to go and take a chest X-ray or a chest CT. This is on top of existing imaging that is already being done. And that's why we like these incidental programs where if you are detecting something incidentally, you're likely to find that early, likely to find disease early. Plus, you're not adding more to the screening cost. You're not saying that patient needs to go out for further screening or further examinations.
Initially, in training the data, you make that company investment, and then for the hospitals or the clinics, it's actually you give it quite cheaply.
Once you develop the technology, it's ready for large scale. I mean, for us, we could be processing 100 million X-rays a day, for example, right? If there are that many X-rays being taken, the AI, unlike humans, can scale to whatever level, right? And it can scale. I mean, I just have to add more AWS cloud servers to scale that across more scans. So the cost of processing an incremental scan becomes very low once the technology is developed.
How should patients be thinking about this? I mean, I go in and I'm having a scan or an MRI. Should I insist or ask my clinic, hey, did an AI double check this? Is that what you think patients should start demanding, given a second opinion is so important?
I think patients can start demanding it. The only thing is that for a hospital to adopt AI, whether on an X-ray or a CT or an MRI, it is a 6 to 9 month long process. I mean, they have to first evaluate the technology, then procure it, sign all the legal agreements. I mean, deploy it. Deployment takes time. So it's like, I mean, if you ask today, maybe you get it 9 months later. But I think we are heading towards that world where ideally every scan should be read by an AI. You should be able to find abnormalities that are then presented to a radiologist who is then reading on top of what the AI already reported. So I think that is a world that we're definitely heading towards.
This is something someone told me, that right now we have the AI kind of, the human double check the AI, but actually it's going to flip at some point where the AI is really the primary source, and people will demand that it checks it first. But maybe that's an era we're going into because of its speed of accuracy. I guess the other thing is, you started this company in India. And why India? Why did you choose India, and what makes it especially relevant for you as a company, for you as a founder?
I just launched in India because I was in India. That's about it. I was in the US for a while, came back to India, and so I was here. So set this up in India. I think the advantages of setting up in India, two things that sort of stood out for me. One was that, especially when we started in 2016, access to large amounts of radiology data in India was easier. We were able to build out a large database of images, and quality of AI is a function of the amount of data you have. So we worked with very, very large Indian hospital groups and were able to get anonymized patient data from them, which went into training our models. And the volume of data, as you know, in India is very, very high. These hospitals see large number of patients, large number of scans. So that data was something that was an advantage, that we could build out a very large database of images out of India. And I think the second advantage we had is that in 2016, these techniques were still very new. So AI talent across the world was hard to find. And what we did out of India is we basically got a lot of people out of these IITs and people who typically would go and work for a FANG company in the US. We got some of that talent to come work for Qure, and we all sort of learned and built out, AI together. So learned all these new technologies. And the best part was that there was a lot of open source code available back then, and still is, right? And you could build on top of that. And with the data that we had, we were able to build high quality models, which then we deployed at some of the best universities or research institutions across the world, and then did a lot of studies which showed the accuracy and the efficacy of our technologies. But data and talent, I think, two advantages that we had starting out of India.
Prashant, when you think about India, people wonder if Asians are receptive to AI, that they trust it or not. What has been your experience using it in hospitals, both in terms of hospital administrators and also in terms of patients?
I think one thing which I want to say is that, honestly, everything that we do is for doctors. So we don't have anything that directly reaches patients. So we don't even know what the patient reaction is. I know that a lot of patients send me scans. I mean, a lot of people that I know send me scans on WhatsApp that can you get this processed by Qure.ai. So I do that. A lot of people want that second opinion with AI, but we don't do anything which directly reaches patients right now. But we work with doctors across the world. And I would say, I think the receptiveness of doctors towards AI is pretty similar across different geographies. I would say if you are in a Apollo hospitals or a Max or a Medanta in India, you're likely to want to use AI, likely to figure out how it can upgrade your reporting, I mean, add value to or reduce, make you more efficient, make you more productive. So I see that that receptiveness is pretty similar across, let's say, Asia and some of the developed countries.
Speaking of doctors, what is kind of the doctor? Yeah, I have a nephew who just is finishing up his residency. Now, you're not a doctor yourself, but you see the future very close up. What do you think doctors should be studying in medical school that they're not studying right now?
It's a very hard question. It's a very hard question. I think it's like, a lot of coding about a year ago, maybe about 10 months ago, people said that coding will become fully automated with AI, right? They said that all these coding assistants are there, they will write code for you and you don't have to write code anymore. But the reality is that you still have to write code. In fact, debugging code that is written by AI is even harder, right? So number of developers has not gone down. People use AI to maybe write some part of their code, right? But they still have to have that skill and that skill set of being a coder, being a data scientist, or writing these algorithms is not going away. A similar sort of approach also applies to doctors, right? I think a lot of skill sets that are developed will continue to be relevant. And I don't know if we are at a point where AI is going to fully automate or automate a large portion of what a doctor does, including physical interaction with patients. Second, I think the most important thing is the fact that even if it does automate a lot of doctors' tasks, regulations won't allow you to automate that from a patient perspective, because finally somebody has to take liability. So the doctor is the person who's taking that liability to provide a diagnosis to a patient. And that is something that AI would not be doing for a while. And I see that, and this is very similar to what is happening in autonomous cars also, right?
Yes.
Autonomous cars would have been a reality maybe 10 years back, maybe 7-8 years back. But we finally saw them on the roads only about a year and a half ago in San Francisco. And then gradually it is scaling up to more geographies, more cities. But then you can also see that a lot of cities in the US are now putting down laws around not allowing autonomous vehicles on the roads. I think regulation is not ready for autonomous AI in healthcare right now, and maybe not for the next 4 or 5 years.
So, Prashant, what about the fact that we have, all of these regulations all over the world? As Qure, what are the guidelines for you as a company? Are you liable if you make a mistake, or is a doctor liable? Is the hospital liable if there's a false positive or a false negative?
So all the tools that we provide are assistive to a physician in making a decision, whether that's a radiologist or a pulmonologist, a neurologist, neurosurgeon, healthcare workers in Southeast Asia and Africa. The end user might be a physician, but finally that physician is responsible for making that decision about a patient's diagnosis. And today, a mistake that physician makes is still their liability. AI is not doing that, and that is true for all kinds of AI. And that is from a liability perspective, but also to add to that, see, everything that we build out is regulated. So we have to get an FDA clearance for all the products that Qure builds. And we have today 19 FDA clearances. And if you look at those FDA clearances, all of them are for assisting a physician in decision making. So whether you are marking out an abnormality on a scan, or you are creating a sort of report, or maybe pointing out to a certain abnormality that is present, everything is assistive in nature. Right now, none of the AI is approved by FDA or autonomous.
So actually, I wanted to ask you about this. You have so many FDA approvals. Like, what does an FDA approval mean, and what do you have it for?
So the FDA approval is basically this, right? What we build is software, but it is classified as a medical device. So if you, let's say, go out and buy a oximeter, for example, or a blood pressure meter, those also need to be cleared by the FDA or by a regulatory body to be commercially sold in a geography. Those are, of course, physical medical devices. Very similarly, when you look at software medical devices, there are FDA regulations around the clearance of software medical devices also. So when we want to commercialize in any geography, and you have to go through the regulatory process, you have to show that the technology is safe and it's effective. And in that, you have to compare against the standard of care and show that as part of the standard of care or added to the standard of care, this technology is useful and it's safe. And that kind of, so we have to do multiple studies to get to show that, to show those outcomes. And in the US, we go through the FDA process. They have certain requirements for what they need from these studies. In Europe, there are the EU MDR guidelines, and every country has its own set of guidelines around software medical devices. So you have to go through that to be able to commercialize a product in any geography.
I'm interviewing the founder of Overjet that actually uses AI to check teeth and identify cavities and helps dentists. But she's partnering with a lot of universities to prepare dentists during their medical training on how to use Overjet. Are you also planning to kind of, that's why I was asking about the academia. Do you see a day where in medical schools, Qure will be a platform that they will be taught on so that they can actually learn to work with it more effectively?
I think so. I mean, I think that's happening. We do run some of these programs, continuing medical education programs, where we are teaching radiologists how to use AI, and not only our own AI, right? Other AI tools also. So we are doing that across geographies. But also, I would add one more point to this is that typically what we try to do is make the AI very seamless. We don't want it to feel like they're using AI, right? Today, for example, if you use Gmail, it has a spam filter. You don't have to think about, okay, I'm doing some spam filtering. It does it for you, right? And you know that there is some spam. If you want to look at it, you can go and check it out. So very similarly, our tools are fully embedded into the doctor's workflow. So radiologists will have a small widget at the bottom of the screen with a small queue. And as they see that scan, they can click on that queue, see what Qure has reported for that scan. And if they want to see further, they can click on that. That will open up another page. They can add a patient into navigation workflow from that small widget. So we've sort of designed our product in a way that it becomes seamless for doctors to use, and it does not require a large amount of training. Very intuitive to use, right? And similar to how we use other AI products, right? All the apps that you have on your iPhone, you don't think about, okay, so nobody's training you on using them.
That's true.
You figure it out, right?
That's true. Now that makes sense from a product perspective. You've kind of made it seamless and invisible, part of the process. Prashant, what about your accuracy? You did say it's accurate, right? But how many false negatives or false positives do you get on average, which are, you can share? And I think that a false positive is also very stressful. And that's the pushback some doctors are giving in the New York Times and others. They're saying people are overdiagnosing things and they are not completely accurate. What's the trend you're seeing in AI's ability?
Yeah. So for your first question about the accuracy, see, I mean, we do about 70, 80 different findings across chest X-rays, chest CTs, and ultrasounds, and so on, right? So every one of those findings has its own accuracy, and we look at sensitivity and specificity. So every one of those has its own sensitivity, specificity, and all of that is published. We have about 200 plus papers, which sort of speak to the sensitivity and specificity of these technologies, right? So that's sort of where it is. Typically, I would say on average, we are at about a 95% to 98% sensitivity, and maybe around 85 to 90% specificity across these tools, right? So that's sort of the average range. Coming to your point, see, a false positive can be stressful to a patient, but that is where our tools are meant for a doctor, right? And if a radiologist is looking at a scan that is reported by Qure and sees that, okay, there is this nodule that is reported by Qure, but I don't see that nodule, they can choose not to take that advice from the AI, and they can choose not to report that nodule, right? That decision making is finally on the physicians to see if they want to then invite that patient for a further CT. But you're right. I mean, if false positives are definitely stressful, and false negatives are even more risky, right? If you miss a nodule, that is cancer, life or death for that patient. So
but this means that doctors really can focus on being empathetic and having better communication skills also, which is something that they've been so busy doing administrative work. It's kind of sometimes, you feel the doctor's too busy. In my case, I feel the doctor's too distracted sometimes to actually say something in a way that one would expect would be a kinder, empathetic way of communicating something. But maybe AI opens that opportunity for them.
Yes, I think AI, not only the kinds of, we have a scribing tool. So it's a note-taking tool as a doctor and patient converse. Doctor does not have to type all the notes into a electronic health record. It's all done automatically by that tool. So it's just listening on your phone or on a tablet sitting next to you, and just records basically summarizes the conversation and summarizes the tests that are recommended, the diagnosis, and provides a summary for the doctor to then click and insert into the electronic health record. So these kinds of tools will definitely enable the doctor to spend more time with patients, and maybe spend more time talking to them than doing the administrative stuff.
Prashant, what's your vision now? You were just in Time 100 AI list. It was amazing. Congratulations. A big deal. And now, what's the next? Are you going to stay with X-rays? Are you planning to cover more countries and more locations or different diseases?
So our goal is to get to more disease areas, and within those disease areas be more comprehensive. So, like for example, like I said, on lung cancer, we do X-ray, we do CT, we do the follow-up management. We also enable multidisciplinary teams in putting all the data together from the EMR. EMR is basically the health record, and the PACS is basically all the images, right? So bringing all the imaging data and the patient history together to make the right decision for that patient on what course of therapy is best for that patient. So we enable all the decision making in that lung cancer journey. And very similarly, we enable a lot of decision making in the tuberculosis diagnostic journey. And we are adding more and more AI and multimodal AI to our portfolio to help physicians make decisions around these specific disease areas, from tuberculosis, lung cancer, heart failure, COPD, HIV, and stroke. So these are 6 disease areas that we are sort of invested into and building around. And in that, around the diagnostics of those 6 disease areas, we will build out a lot of AI around imaging, around patient navigation, around EMR, risk scoring. So multiple things that we are building around these disease areas.
What keeps you up at night in terms of when you're deploying so much AI? What worries you?
I think it's the risk. I feel like the biggest risk always is the fact that AI could be wrong, and you always have to strive to keep on improving it to make sure that you don't make those false positives and false negatives, right? You'll always have false positives, false negatives. The point is, how do you set up process around it to ensure that nothing goes through, and you always end up with the right diagnosis for the patient, right? And how do you work with the doctors to ensure that they take care of the false positives and false negatives? So for us, the most important thing is to just keep on working on the AI, keep on improving it, and make it more accurate, make it more comprehensive as we scale.
Prashant, you've worked in so many different countries. Which country has really surprised you in its quick adoption or its openness to adopting Qure?
Not a country, but I would say Africa. We are in all the sub-Saharan African countries right now. And we are in probably 1,000 plus out of 4,500 sites that we are live in across the world. Maybe 1,000 to 1,500 are in Africa. And the adoption, the scale at which we have been able to deploy there, how they have adopted our TB screening product, I think has been surprising to me. I didn't expect that 3-4 years back, but we've seen a massive amount of scale in Africa.
Is it just because they need it and they're just youthful, or what is driving this adoption?
I think the need is very high. Like I said, there are not enough radiologists reading those scans, and if you can have AI which is getting you a report in 30 seconds, you would use AI. Why would you then try to find a radiologist who's not easily available? So I think that need is high, and they have been quick to adopt it.
What does a country need? Like, if I had to think about it, you would say, if you want to work with Qure, if there's somebody who runs a clinic somewhere, what do they need to onboard Qure for their patients?
Internet connection, that's about it. they need internet connection, they need some X-ray or CT scanning capability, and that should be enough for them to start onboarding Qure. And deployment is easy. I mean, I think the lot of times when you deploy at large health systems, the IT teams and integration, all of those take time. But if I had to deploy at a hospital, I live in Mumbai, at a hospital in Mumbai Municipal Corporation, it might take me half a day to just deploy there, and they could go live by end of day today.
That's amazing. Prashant, this has been such a great conversation. And it's relevant not only to hospitals, but actually to each one of us as people who are humans always grappling with illnesses. Thank you so much for your time today. It's great to connect with you while you're in Mumbai, but I hope you will come to Singapore soon and we can have a cup of chai and discuss AI some more.